Now I have the extreme pleasure to introduce our next speaker, and I need to invoke the cliche, this person needs no introduction. Because all of you know this remarkable person and her remarkable story. Dr. Tracy Dixon Salazar, PhD, is a neuroscientist, geneticist, and dedicated patient advocate who serves as the executive director of the Lennox-Gastaut Syndrome Foundation. Motivated by her daughter Savannah's battle with LGS, she earned her PhD and completed postdoctoral training at UC San Diego, where her research led to a precision therapy that dramatically improved her daughter's quality of life. Tracy, thank you for all you do for the foundation, and let's welcome her to the stage.
Thank you, Fred. I'm excited about the third day as well, so I think it's going to be great. I'm struggling a little bit this morning but Caleb, are you in here? Where are you? There you are. Caleb, thanks for helping me get out of bed this morning, buddy. He's all right, rock on. Caleb is here, and he's one of our LGS loved ones, and they are deeply loved. I'm going to talk just a little bit about the session and why we're here, but I really want to talk about evidence-based care and why we want it as patients and families. And before I do that, I want to set the stage briefly, because if we don't define it for the purposes of what we're doing, if we don't measure it in ways that we have meaning to all of us, then we're never going to improve it. We're never going to make care better for families. So for the purposes of this meeting, we're using the International League Against Epilepsy definition of LGS. Elaine's going to talk a little bit about this, so I'm not going to go into a lot of detail. But there is a very specific definition, and for the first 20 or so years as an advocate, all we talked about was, well, what really is LGS? Well, I'm happy to report we know what it is, and this will allow us to really target it and change it. We know a lot about the fact that it's a secondary network disorder. Nobody's born with it. It evolves over time from early life seizures, and everyone with LGS develops very specific abnormal EEG biomarker. The brain waves are abnormal, and specifically this EEG characteristic, GPFA, or generalized paroxysmal fast activity. And so when you think about this network disorder, it evolves over time, right? So you'll have a cause of the early life seizures, and we know a lot about what causes seizures that can then evolve into LGS. Everyone has LGS secondary to something. And then, that will lead to their first seizure, and then their second seizure, and then ultimately they have epilepsy, and if they fail 2 treatments, they have treatment-resistant epilepsy. And then somewhere around the age of 5 or 6 in greater than 90% of people with LGS, they will develop the characteristic EEG features of LGS along with the clinical symptoms. So with this evolution to a secondary network disorder, there's all these points where we can intervene. And we don't have highly effective treatments, and that's something that we all need. But there's a lot of ways that we can improve care now and begin to start thinking about how we're going to improve care. And so each of the arrows at the top of the screen represent how we can intervene. Can we prevent LGS? We think so. We think so, and in the more than $2 million that the foundation has funded since we started funding in 2014, we funded a lot on identifying the early factors and on who's at risk and looking at the EEG as they evolve, and can we target those things to try to prevent it? And this is a big thing for us. Can we stabilize it? Once you have this abnormal brain network, the number of seizures that you have is exponentially higher than what it was when you just had your etiology. So can we stabilize this? And we spend a lot of time thinking about how we can do that. And then can we, once you have it, think about preventing the evolution that happens after you have it, the widespread brain atrophy that happens, the cognitive regression and impairment, the behavioral dysfunction, right, and the premature death, right? Can we think about that? And then can we reverse it? We know anecdotally in the literature that there are cases, and we know patients and families who are like, they had LGS, but they got their seizures under control, and then they didn't have it anymore. The EEG righted itself. So these are all areas that we're focused on. And each person with LGS will have many diagnoses. They have this syndromic diagnosis, but they'll also have a seizure type. They'll have an epilepsy type. They'll have the thing that caused their seizures to begin with. And then, of course, all the comorbidities. So when we think about defining this is what we're looking at across care, but our families have told us where to focus. Where we really want to focus is on seizures and safety. We asked them in 2018, we did a survey, we're about to do another one, and they said, please help us with seizures and safety. So if you've ever heard the term, I have epilepsy, but epilepsy doesn't have me, we don't say that in LGS. LGS, the epilepsy has us. We're cornered, it controls our entire lives, it has us. Right? And you don't hear us say, oh, epilepsy is more than just seizures. It is. It absolutely is. But in LGS, we just say, can you just do something about the seizures, please? On a good day, when my daughter was young, seizures were 5 to 10. On a bad day, it was hundreds too many to count. And we lived that way for 16 years until we found a treatment that helped her. And she went 11 years where she was doing really, really well. And then she developed COVID, and her seizures came back. And then 2 years later, 4 months ago, she passed away in her sleep from SUDEP. And largely, the journey has been really without evidence. We have evidence that there's a lot of medicines that are effective in seizures, and a lot of dietary treatments and neuromodulatory devices, brain surgeries, but we don't really know how to use them. We have this arsenal, and we have many caregivers in the room, and each of us, our loved ones, has tried a different combination in a different order, and no one anywhere has really written that down in a systematic way where that our daughter's 30-year journey with LGS could benefit Caleb, who is not yet reached that age, right? Or Grayson, who's 11 years old, or Cassie, who's 4, right? And so we're seeking to change that. And there's a lot of gaps in the space that we need to focus on. And so we chose evidence-based care as the topic for this meeting. And often when you think about evidence-based care as healthcare providers and researchers, you think about the evidence-based medicine pyramid. And I think this is really important. There's different levels of evidence. Of course, we want level 1 evidence on everything. We want to know what it's going to work and who it's going to work in at the right time, every time. But everything starts out as lower level evidence before it gets up to that point. And journeys have largely been without a lot of evidence on how we make decisions. And so while we're focused on evidence-based medicine as doctors, I think that we're really focused at the foundation on evidence-based care. What is the evidence that we need to make decisions as a healthcare team in order to treat our loved ones? When my daughter was in the pediatric epilepsy system, which she was in till she was 21, and then she left, and then she came back, and then she left again to adult care, and then she came back, and then she left again to adult care. The problems we had were not just that there was no highly effective treatment, but that we try them in every permutation and combination, and we're not following, there's no expert consensus opinion on it. If you're lucky enough to get to expert, that's great. But we really don't have any decision. It's really, you go to the doctor's office, you sit down, they offer you 3 options because they've done this amazing calculations in their head that no one fully understands. And you're just supposed to pick from those 3. And we want to change that. We want to try to figure out what is going on in the head of the experts, and then bring that to bear on the treatment across the board for everyone with LGS, and then begin to learn when the experts disagree, well, it could be this, or this. Can we start to do research to really figure out which of the this, or this is the most effective at stopping the seizures? And we'll just take stopping the seizures. Listen, we have sleep issues, we have behavior issues, we have GI issues, we have mobility issues, we have got issues beyond issues. But it's hard to imagine When your loved one, Savannah in her many, many years had more than 40,000 seizures. It's hard to imagine anything related to behavior or sleep or GI or mobility getting better without first addressing the seizures. We don't know how to prevent aspiration pneumonia, which Savannah would get every year. We don't know how to prevent status. We don't know how to think about SUDEP in our communities. In 30 years, we never had a single physician that we saw speak to us about SUDEP, never. And that's by and large the truth across the board. We don't have any evidence on how to manage the comorbidities that I just mentioned as they relate to seizures, right? So if you have somebody who's having a lot of seizures and they have behavior, what do you decide with treatment? What do you decide with care? If they have certain specific types of seizures, but they're also sleeping all day or they're not sleeping at all, what are the decisions? And then there was no long-term care plan. And then every complaint I had about pediatric care, when we got to adult care, I take it all back. Everything I said bad about pediatric care, I take it back, because adult care, it wasn't even the Wild West. It was just it was prehistoric, is what it was. And the way transition happened is we got a letter from our doctor at a level 4 epilepsy center who sent us on our way to go and find our own doctor. And when we got on the other side, it took us about 15 years to realize that he gave us a football to take into a baseball game, which was being played on the other side of the country in a completely different location with completely different set of rules. And nobody really sets us up for that sort of understanding. And then when we get to adult care, there's a complete lack of understanding and education for physicians on what LGS is. Our seizure action plan was go to the emergency room and let's make sure we check levels of her medications and make sure she doesn't have, an ear infection. And we spent the entirety of pediatric care avoiding the emergency room. There's no long-term care plan, and there were a lot of doctors who really just don't even want to see our patients, which is really disheartening because we can't give up. And so there's so many barriers. And so when we think about care, I would just ask that we try to put it in the framework of what are the questions that our families want answered. It's great to then go back to the evidence-based medicine pyramid, but how can we begin to really address the issues? And one issue that is going to be absolutely undisputed is how do we use the treatments that we have today? We're so lucky. We have a whole arsenal of treatments. Many diseases don't have that. But we're unlucky because we've not invested the time and energy to figure out really how to optimally use them. And to the point that the treatment odyssey is almost worse than the diagnostic odyssey, because it goes on for years and they by and large don't work. So that's what I mean when I say we want evidence-based care based on evidence-based medicine. And we appreciate you being here to help us to figure out how to move forward. We have very specific goals from this meeting, and they revolve around how we intend to invest our next $2 million in research. We've made a big difference. We've talked about prevention, stabilization, potentially reversal, potentially thinking about not getting worse in LGS, but then how can we think about care and that actually getting better for our loved ones? Because that will end some of the suffering. If if our families don't ever have to get on the phone again and argue with insurance companies, or you don't, right? That will improve care. If we knew what treatments worked and when and in who, that would end some of the suffering, which is our goal. So I'm going to talk just for a minute about the next set of slides, which I think are part of me, but it's like the housekeeping and the meeting overall. The meeting is called Advancing Evidence-Based Care Across the Lifespan. And do you guys have the slides, Sue, from the other set of slides that I'm going through that are talking about the meeting objectives? Great. All right. These are supposed to go first, but that's all right. So the objectives of the meeting are really specifically to, at the highest level, define our funding strategy moving forward. We've had several of these meetings already. One really focused on disease-modifying therapies and basic research, and we funded in that area, and then also on clinical trials and making them better. So we have very specific objectives that we're focusing on for this meeting. And we brought together a multi-stakeholder group. We have patients and families in the room. We have healthcare professionals. We have researchers. Our industry partners are here. Educators and family members are all here. So I just wanted to say thank you guys for all being here and helping us navigate this. We want to leave this meeting with this idea that at the end of, of day one, we'll have an idea of the areas and the gaps in care that are most compelling, that we think we can address. And so we have a really exciting session for session one, where we're going to be looking at what are the gaps in pediatrics, what are the gaps in transition of care, what are the gaps in adult care, and then really trying to narrow those down to the three main topics that we want to focus on at the end of our day tomorrow in the breakout sessions. And from there, this will really help guide our strategy. There's so much that we can do, but a lot of what you do and what you invest in really depends on the people, who's willing to do it. The unanswered question, of course, is driving us, but is there energy? Is there even anything we could do? Like, I want to cure tomorrow, but I don't even know how to define cure where we would all agree, right? So that maybe isn't what we're going to get tomorrow, but tomorrow we can start to think about how can we start to optimize treatments in patients, for example. And then we have good sessions going on tomorrow where we're going to get in the nitty-gritty of research, and then again dive into the really exciting research that's coming out now, where we're looking at, again, prevention, stabilization, and potentially treating the EEG, specifically the biomarker in LGS. So we're really excited about that. And then we want to leave this meeting with an idea not only of all of the gaps, there's so many, just talk to any family here. There's just an unlimited number of gaps, but also where there's excitement to fill those gaps, where there is energy and interest in filling those gaps. And we intend to publish a summary from the meeting. We're very excited about this, and we really can't thank any of you guys enough for being here and helping us to move the needle. LGS is absolutely devastating. And a lot of the suffering is stuff that we can't do anything about. But with research, we know that we can begin to start ending that suffering. Some of the suffering is needless. We can figure out which treatments are better than the others. We can do that. It's going to take time. It's going to take money. We can figure out what the emergency department protocols are. We can figure out, how to share data and how to do research that's going to move the needle. And we're going to start now. And the foundation has taken this on and is committed to improving care in the areas where we can end some of the unnecessary suffering with this disease until we have highly effective treatments. We're going to keep looking for those, but there's stuff we can do now. So with that, I just want to say a few words of thank you. So I'd like to just say thank you to our sponsors for this meeting. Many of you are in the room. A special thank you to Lundbeck, who is our patron sponsor. This is a group of companies that have all dedicated themselves to trying to find better treatments, whether they're medications or neuromodulatory devices, to help our families. And we can do all the science in the world, but if we don't bring them to market to patients, then they're never going to have access. So thank you guys for making this meeting possible. I want to say thank you to our organizers, and if you guys all want to take a moment to stand up just so I can make sure you're all here, I'm taking a roll. No, I'm just kidding. Elaine Worrell has been incredible in helping us. Dr. Scott Perry has. Fabio Nascimento, I think I see you back there. Renee Schellhaas, I see you right here. Elizabeth Gerard, I think there you are, our adult neurologist who's dedicated to helping us change things. Jennifer Galinas, are you in here, Jennifer? I don't know if Jennifer's here yet. And then Peter Crino. Pete, are you here? All right. Anyway, we have an incredible meeting planned, so we're just going to get going on. But thank you guys for helping us to organize this. And then thank you to all of you. A big thanks to the families who are in the room. I know firsthand how hard it is to leave your loved one with LGS and then fly anywhere, drive anywhere, do anything. So thank you for being here to bring your voice to this. And again, to all of you in the room, to our healthcare partners, to the researchers, to the fellow advocacy groups that are here, thank you. And then lastly, but absolutely not least, I want to thank our dedicated volunteers. To pull off a meeting like this is so difficult. And I just want to thank our board of directors, all of the volunteers for this meeting, and then also to our incredible staff who has made this meeting possible.